Okay, sir. Now we are live on YouTube.
Okay.
We are this recording. We have started. So at the outset, I welcome Dr. Suryakant, whom I know since many years, because he is a person who introduced and insisted me to use PRP, and I was amongst the quite a few person from this region, at least, who wholeheartedly adapted the PRP treatment, and definitely it has benefited uh, many patients, if not all patients, at least many patients it has benefited. So PRP, we have reasonable experience, but we do not have any experience about the stem cells. And suddenly the call came or message came from Dr. Suryakant that he has designed some very simple way, the kit, and the procedure is so simple uh, that anybody and everybody can uh, take help of this modality in resistant cases. So I welcome Dr. Suryakant. So I requested Dr. Suryakant to please deliver some talk because a lot of questions keep coming regarding the PRP and bone marrow stem cells and all those things. So I requested him. He was little hesitant, quite busy, but then I insisted, and he has just came to his native place at morning. Morning he started in the morning 4 o'clock, and he reached I think a couple of hours back only. Ne? Am I right, Doctor Sridhar?
Yes, yes, just half an hour ago.
Half an hour ago. So still I said no, sir. We have to do so must go on, and we have already decided. We have fixed up the appointment. So please do not delay. So over to you, Dr. Suryakant, sir.
Thank you, Dr. Kodia. It has been pleasure from my side to be to present all these things to you. I have tried to make a simplified version of platelet as well as stem cell things, and I would like to present whatever I feel like. And whenever you have any doubts, any questions, you can ask me anytime because I am there to answer all your questions. There have been a lot of hypes about PRP as well as stem cell therapy, and I try to reduce all those hypes, going to the brass tacks and going to the basics of it, and I try to make it very simple. Now, as you all know, platelet-rich plasma therapy is defined as a portion of plasma fraction of autologous blood having platelet concentration above baseline. This is very, very important. PRP is becoming very popular therapy for a variety of conditions, including aesthetics, rejuvenation, degenerative, and musculoskeletal conditions. The balance between degeneration and regeneration is restored in favor of regeneration by using PRP. By definition, PRP is platelet-rich plasma, and there is a great variation in the reported results of PRP therapy. Though PRP is being used all over world for a long time, there is still a confusion over proper terminology to define, classify, and describe the different variants of the platelet concentrates. There is also a wide variation in the reported protocols for standardization and preparation of the PRP, in addition to lack of accurate characterization of these tested products in most of the articles. High cost of commercially available PRP kits reduces its use over a larger population. Basically, as we all know, body regenerates itself, and no medicine or surgery can be effective if the body cells and tissues do not respond. The potential of body to regenerate and repair itself is very unique and depends on cell-to-cell stimuli comprising of chemical stimuli, hormones, neurotransmitters, nutraceuticals, and the medicines. With aging, the disease conditions, cells lose potential to respond to these stimuli, and repair and rejuvenation gets delayed. This is seen in most of the chronic inflammatory diseases as well as in diabetes. If we can restore cells' potential to react to these stimuli, repair and regeneration can be hastened. Platelet-derived growth factors have such a magical properties which have been recently recognized. PRP is basically derived from human blood, which contains 55% plasma and 45% RBCs, with very minor volume occupied by platelets and WBCs. Normal blood has 1,50,000 to 4,50,000 platelets per microliter, and PRP preparation involves concentration of these platelets into small volume of plasma enhancing concentration of the platelets in that volume of plasma. Efficacy depends on the ability of properly concentrating platelets and using appropriate volume for the purpose it is used. As you all know, the platelets are very small, tiny blood cells derived from megakaryocytes. They are devoid of DNA, very small size, 2 to 3 micron in size, and contain dense granules and alpha granules. This is how they look like in the peripheral smear. And this is the electron micrograph of the platelets, which is seen where we see the different kinds of granules. Now, the main function of platelets is hemostasis by attaching to any breach in vessel where platelets aggregate, activate, and release granules. The platelets organelle zone is rich in platelet granules. Alpha granules contain clotting mediators such as factors 5, factor 8, fibrinogen, fibronectin, and platelet-derived growth factors, and chemotactic agents. Delta granules or dense granules contain ADP, calcium, serotonin, which are platelet-activating mediators. Now, platelet-derived factors are very important for different tissue regeneration processes. Activated platelets release these granules by exocytosis, which contain not only clotting factors, but 60 different biologically active substances that are involved in the process of tissue regeneration, angiogenesis, epithelialization, proliferation and differentiation of osteoblasts, and synthesis of collagen. Now, these are the different platelet-derived factors which are important, like EGF, PDGF, IGF, VEGF, TGF, KGF, FGF, and all these are very important. They have different roles in the platelet function. PRP is basically prepared by a process known as differential centrifugation. In differential centrifugation, acceleration force is adjusted to sediment certain cellular constituents based on different specific gravities. Now, methods of preparation can be classified according to the process used. The classical double spin in the tubes, double spin using syringes, double spin with vacutainers, single spin with gel tubes, buffy coat with single spin, and various special device techniques which are developed as kits. Now, these are the gel tubes. This is a device which is used by some company which is importing it from USA. And these are again different types of gel tubes in different packaging, though they are same, because of the packaging, they look different. Now, the process of PRP is initial centrifugation of separation of blood cells from RBCs is followed by second centrifugation to concentrate platelets, which are suspended in a small final plasma volume. This is how it looks like after first centrifugation, and the second photograph is after the second centrifugation. After first centrifugation, the plasma is separated into second tube, and then it is centrifuged again. After the centrifugation, you will get a pellet at the bottom, and leaving behind a small volume of plasma which is desired for that particular treatment therapy. Rest of the plasma is removed, and then the platelets are resuspended in that small volume of plasma. This is how it is being prepared. Now, evaluation of method also is very important, because each method can be evaluated on these criteria. The criteria are yield, concentration, dose, and activation. Yield is a very important, and it shows the efficiency of the process. It is the ability of the method to extract all the platelets in the collected volume of blood into final concentrate. Yield achieved ideally should be above 90%, which is not possible by any single centrifugation method. Concentration is enhancement of platelet count in the final prepared volume. Lower the concentration compared to native blood plasma count, lower will be the effect of PRP injection. It is desirable to achieve concentration of 7 to 10x, and for the case of endometrium, we require 30x concentration compared to the native blood to get proper effect. This can be achieved only with the double centrifugation technique. Dose is very important. Dose is the amount of platelet concentrate used of the 7 to 10x concentration used per unit of tissue. For example, we use 0.1 ml of PRP concentrate per square centimeter of skin surface area for skin rejuvenation. Similarly, using specific volumes to be injected in the joints. Appropriate quantities of blood must be collected to get proper dose. Using smaller tubes defeats this purpose. Activation is also important, and it's required for release of growth factors. In certain situations, you need to do activation, but otherwise, when we are injecting the PRP in the tissues, we do not need any activation. Activation can be achieved by using calcium ions, thrombin, various platelet activating factors, and simply by the mechanical disruption of the platelets. Chemical stimulation with calcium ions and thrombin takes few minutes to few hours to completely express the growth factors. Mechanical disruption on the other side will be very effective in certain situations where we need instant growth factor release. Each method of preparation and kits and tubes should be evaluated against these parameters of testing. What are the benefits of PRP? People have used PRP in different situations, and it has become an almost all-round therapy. It's used in almost all the disciplines of medicine. Every faculty of medicine is benefited by using PRP treatment of specific conditions requiring repair, regeneration, and restoration. Healing of musculoskeletal diseases, repair of nerve damage, injuries, repair of muscle damage, bone repair, plastic and cosmetic surgery, oral surgery, wound care, hair regrowth, facial rejuvenation, dry eye treatment, thin endometrium, ovarian regeneration, premature menopause, O-shot, P-shot, vampire bracelet. All these things can be achieved by using PRP. Now I will talk about the PRP in endometrium. Proper endometrium is one of the most important main factors for the achieving pregnancy in assisted reproductive technology. Estrogens, low dose aspirin, GCSF have all been variously tried, and it's very difficult to get those results. This is the original article which came first in the literature, Chang et al., who have shown almost 7 to 8 patients which have achieved the results after only one injection of PRP. Intrauterine infusion of PRP is used in endometrium with the view that the growth factors provided by the platelets will help in the restoration of deficient endometrial function. PRP is prepared from 15 ml blood using double centrifugation technique, and final preparation of 0.5 ml is infused on 10th and additionally on 13th day of cycle after doing the mechanical disruption by using the multiple freeze-thaw technique. Patients can be selected on the criteria of previous cycles showing endometrial development of less than 7 millimeter even after the other therapies. These are subsequently received studies which people have shown it is very effective not only in thin endometrium but in the implantation failures also. We can use the same method for PRP in ovaries. PRP early ovarian failure is a baffling problem which is not treatable very easily. Early menopause with the decreased anti-Mullerian activity is a challenge in the infertility management. So PRP application, the ovarian soft tissue aims at cellular growth and proliferation in the ovaries. Published series of 8 perimenopausal women showing return of ovarian activity in 3 months. Based on the knowledge and predictable endothelial and vascular growth activities with PRP application and the stimulation of stem cells, results are expected even in recent menopausal ovaries also. Based on the knowledge, scientific evidence is still lacking because there is not the large series which has been published, and people are very reluctant to publish because they have gained the results and they don't want to share it with others. And it has happened like this, that PRP, though it works, it is not being talked much about. We can do a scientific evidence ourselves by doing a small group of patients, and the best group of patients to select are those where laparoscopy is indicated for any other reason. Little peripheral thing which I can talk about is female sexual dysfunction. It's an enigmatic problem with no specific treatment modality available. It is characterized by decreased libido, vaginal dryness, dyspareunia, decreased genital sensations, difficulty and inability to achieve orgasms, and orgasmic disorders, for which we can definitely use O-shots, which can result in greater arousal from clitoral stimulation, increased sexual desire, arousal, and libido, tightens the introitus, stronger and more frequent orgasms, increased ability for vaginal orgasms, increased vaginal lubrication, and improved control of the urinary passing. Now, this is where we have to inject around the scalene glands and around the bladder neck and in the clitoris. These are the injection sites. Another peripheral thing which I would like to talk about is PRP for breast augmentation. Just like men associate some of their masculinity with the shape and size of their muscles, women associated some of their femininity with the shape and size of their breasts. However, unlike the muscles, neither exercise nor massage be of much help for augmentation of the size of breasts. And we can use PRP along with the plasma derived biological fillers to use the breast to achieve the breast augmentation. Similarly, male erection dysfunction also is another important problem where inability to achieve and maintain the erection is a major male sexual dysfunction. It leads to major psychological disturbances and marital discord. Small penis is another major problem faced by Indian males. We have done almost 375 P shots till this time with the help of one urologist, and we have got very good results. People who were taking large amount of doses of medicine, they didn't require any medicines to achieve any erection. Third use is PRP in cosmetic gynecology. Aesthetic procedures, cosmetic procedures, plastic surgery procedures are becoming very common, and PRP is one of the mainstay to provide the growth factors in that. Cosmetic gynecology has come in vogue because of fashion industry, social pressure, peer pressure, sexual partners' expectations, and sex appeal and sex fitness requirements. Cosmetic gynecology basically is a demand and supply situation to please the partner, to make normal ugly. There are ethical concerns, but there is a growing popularity of cosmetic gynecology these days. And we can these are the different procedures which are used. Non-invasive procedures are chemical peels, lasers, radio frequency. Minimally invasive are Botox, PRP, fillers, invasive lasers, and invasive procedures are surgical procedures. Basically, surgical procedures which are used in cosmetic gynecology are either hymenoplasty, vaginoplasty, labioplasty, pudectomy, and monsoplasty. You would know better because I am a pathologist. I won't know much about this. What are the contraindications for doing PRP? There are few contraindications for using PRP. Few of them are like steroidal use, long time steroidal use. You cannot do PRP in those cases. NSAIDs for long term use has to be stopped before we do PRP therapy. Hematopoietic malignancies is the absolute contraindications. Anemia and thrombocytopenia are relative contraindications. What do we know about till today? Ideal concentration of PRP is not known till today. Best technique for doing PRP preparation is not known. Best commercial preparation methods are still lacking. Now I'll talk a little about the stem cell therapy. Dr. Cordia and myself have been talking about the bone marrow stem cell therapy, and people are very reluctant to tell how their results are and how they are doing it. I would like to tell you the simplest procedure to do, which can be easily done in very small setup with a small laminar flow and a small centrifuge. Stem cells are present in the endometrial tissue. Now, tissue cells can be stimulated using the growth factors like GCSF, PRP, and others. And stem cells can be supplemented using stem cells coming from bone marrow or adipose tissue-derived stem cells. There is a recent report of endometrial reconstruction using autologous bone marrow stem cells followed by conception by IVF in 2 patients, which has gained considerable attention and seems to provide breakthrough for conception in IVF cycle. Lot of centers are doing bone marrow stem cells injections in endometrium with good results. Results are generally not published to keep the protocols secret so that their results don't get duplicated. Aspiration and processing of bone marrow to isolate mononuclear cells and stem cells is not a rocket science, but can be done in very simple setup. Detailed evaluation and research level work only requires high level setup. Simple density centrifugation technique gives 90% yield of stem cells with the minimal contamination of unwanted cells from the bone marrow. This is the simple procedure which I have prepared, and this is my kit procedure. Kit procedure contains we collect 20 ml bone marrow is collected from the posterior superior iliac spine using Jamshidi needle in an anticoagulant in a proper proportion is used while collecting. It is diluted 1:1 for using further diluent. Then bone marrow is layered over density medium and centrifuged. RBCs and WBCs precursors go below the density layer. Mononuclear and stem cells are at the interface between the plasma and the density gradient, which we have to pick up. After discarding the plasma, mononuclear layer is carefully transferred to second tube and then washed using the washing medium. Finally, it is suspended in a super concentrated platelet lysate growth factors. Prepared suspension of BMDSC is then injected in the endometrium using hysteroscopic visualization at various sites, 0.2 to 0.3 ml at each site, injection site. Generally, 2 to 3 ml cell suspension in the growth factors is prepared. Follow-up of patient is done for 3 months. Additionally, estrogens, progesterone can be added to the stimulation cycle and for the good endometrial response. Why do it? It is very easy technically. No high lab is required if you are interested in only the final results. Inexpensive using the kits. Results are highly satisfactory and potential to help large number of patients and hopeless cases. Thank you very much. I think I will stop here. I'll take questions whatever they are.
Yes, thank you so much, sir. It was a really very precise and useful presentation, and really we got a lot of insights. Now I will invite some questions. You can unmute yourself if you want to ask the question, please.
Hello, sir. I have a question.
Yes,
In
ma'am.
what patients would we want to do the platelet activation, and how do you do it?
See, basically, when we have to do platelet activation, it cannot be done by standard chemical means when we are doing it in endometrium. For endometrium, it is best to do a mechanical disruption of the platelets by using 3 freeze-thaw cycles in liquid nitrogen. And
How
I have
exactly,
found
sir?
that works very well.
No, we have to dip into the liquid nitrogen, or
See,
it's
what you
just
have
in
to
the
do is
vapor?
once you do the concentration, final concentrate, when you mix the platelets, has to be dipped in the liquid nitrogen for 15 to 20 seconds. It will solidly freeze. Then you just roll it in the palm. It will thaw within about 1 to 2 minutes. Once it thaws completely, you mix it well, again do the freezing. So you can repeat this 3 times. And then this lysate is used for endometrium. Why we have to use lysate in the endometrium? There is a very specific reason behind it. Because when we are putting it in the endometrial cavity, whatever we put in the endometrial cavity will remain there for maximum half an hour. After that, it will be completely removed. So that the platelets which are intact and they are put in the endometrium, they don't have enough time to remove to release the growth factors and to act on the endometrium. So when we have released growth factors, they will be rapidly absorbed during that half an hour and they will be taken up by the cells, including the stem cells, and they will start working.
So I did try it, sir. I did try this dipping 2 times in the liquid nitrogen, and actually we saw that the platelets, they did get disrupted. But my question is that when we are instilling it in the endometrial cavity, will that be effective, or we need to inject them inside the endometrium and then only it will be effective enough?
No, injection is not required. See, I am trying to simplify the procedure, including the lowest morbidity for the patient. Whenever we are going to inject in the endometrium, you require hysteroscopy, you require anesthesia, you require a lot of support, which is not required when we are instilling in the endometrial cavity. Once you put it in the endometrial cavity, whatever is in the solution form is rapidly absorbed in the endometrium.
It will
sir,
not.
Sir, can you stop sharing the presentation so that we can see the face properly, video properly?
So, sir, will it not further cause adhesions and all with all those growth factors? Rather, it will cause rejuvenation. This is the dilemma which comes in my mind when we are instilling it rather than injecting it. Maybe Kuraria sir, you can add something onto this?
No, in fact, it will not lead to synecdoche formation. If the endometrium is intact, endometrium is not injured, it's not going to lead to synecdoche. Synecdoche are formed only when there is a great injury and the growth happens with the 2 surfaces opposing each other.
Okay, thank you so much, sir.
Sir, there are a lot of different terminologies which are used when we go through the literature, like pure platelet PRP, platelet poor PRP, leukocyte rich PRP, and all those four types PRP preparation is there. If you take Buffy code, then it is a WBC rich PRP and something something. Then again, controversy regarding whether WBC are desirable or not, because one school of thought says that if the WBCs are there, it will initiate the inflammatory action, and another school says that no, it is not good. So, what treatment or what procedure you recommend with your kid, which picks up which type of PRP?
Yeah. Basically, whenever we are preparing a PRP by double density gradient centrifugation, most of the times, majority of the WBCs first go with the RBCs because they are denser than the platelets. Now, platelets will remain in the plasma layer when we do a proper differential centrifugation of 15 ml quantity and 1500 RPM centrifugation force. Now, with that, plasma will have majority of the platelets. WBCs will go with the RBCs, or maybe they will form your little buffy coat. And then when we take out the plasma, majority of the WBCs will be left behind. Again, whatever WBCs are left there will be causing some inflammatory response, right? But they are already there in the body everywhere. They already are causing inflammatory response. They will go and they will selectively form the response only when there are chemotactic stimuli. Now, when there are no chemotactic stimuli in the tissue, the WBCs will anyway perish.
Okay. So now, sir, being a ART consultants, we all are facing and all feel helpless when it comes to the persistent thin endometrium.
Yes.
And second, when the patient is not willing for donor oocytes and still insisting with their own using own oocytes, especially when there is a very low ovarian reserve. So these are the two areas where we really feel helpless. Now,
Yes.
if you compare, now we have two modalities, for example, which is practically of great use. That's PRP and bone marrow stem cells. So, uh, cost versus efficacy in both scenario, what is the difference?
I don't think there is much difference, but what has happened is people who are already doing and they are secretly keeping the things. What has happened is the costs have gone astronomical, whereas the cost of kit as a basic thing is very low, even for the both, even for the
Sir,
PRP as well as bone marrow. I am ready to teach everybody how to do it very easily.
sir, I want to ask whether can we take the message that first PRP to be tried, and if it is
Yes,
not effective, then bone marrow should be tried,
yes.
or something like that.
Yes, of course. See, basically, PRP installation in the endometrium is used for patients where we have thin endometrium, but still are not giving any pregnancy, though they are menstruating and they have ovum available. In such cases, what we do is in the treatment cycle, we do twice installation of PRP and see the response of endometrium. If it is working fine in one or two cases, 1 or 2 cycles, then you go ahead with the PRP only. If it is not happening, the second line treatment is you inject the PRP in the endometrium directly by hysteroscopic means. This is the second line. If that also doesn't work and patient has Asherman syndrome or patient is not menstruating at all, in such cases, bone marrow stem cells are the best response, best option.
But then bone marrow stem cells are to be injected actually inside the
In the
endometrium.
endometrium. In
It
the
cannot be
endometrium,
injected in the cavity. It cannot be
yes,
injected
not
in
in
the
the
cavity.
cavity. They will not work in the cavity. They have to be injected inside the tissue.
Okay. And second thing, sir, you have not mentioned how to use bone marrow for ovarian rejuvenation.
Same way, whatever bone marrow you prepare, you put 0.25 ml of the suspension in the ovaries in the cortex.
Okay.
Excuse me.
Yes, Dr. Nupama.
Hello.
Yeah.
Sir, please explain the process to prepare PRP and stem cells.
You want the exact procedure, how it is done?
Yes.
I think for that, it would be better to have a small workshop, because then showing
Yes,
it.
sir, that will be nice, sir.
Yeah, that would be nice. Because otherwise, the procedure is very simple. Wherever I have taught people doing it, they have started doing it on their own. I am almost working like a phone a friend to these people.
Maybe you
So
can
now how
Yes,
to go ahead,
video,
sir?
sir.
How to go ahead? Because our group is, sir, it is consisting of more than 800 IVF specialists who are eager to exchange their knowledge and learn something new every day. So, as you suggested, workshop to be conducted, can it be possible online or how it is to be done?
It should be possible online, but it has to be done in one of the centers.
Fine, fine. So, and you are, sir, you are based on Jalna, right?
I am based in Jalna, but I travel everywhere in India.
So, because see, I am ready to do that, but then you have to come, sir. Na? So, if by chance, if you happen to come anytime to Mumbai, you are most welcome, sir. And
Sure.
we can always do it,
Yes.
and we can record the procedure. And if
Yes.
time permits, then in advance we will inform all of our group members so that they can witness actually when the procedure is going on.
Sure, sure. And anybody who is
Yes,
interested in doing it in advance, even before that workshop, I'm ready to teach them, even on my videos, whatever I have, I can send them by WhatsApp.
That would be
Yes, sir.
lovely.
I have seen you are very cooperative, sir. As you always pick up a call and guide whenever some query because I have experienced it when the PRP was new, and that was something the which everybody, I mean, especially me, wanted to know more and more technically. So you guided very nicely, sir. Thank
Since
you
your
for
contact
that.
number is given, we can start off even before the workshop also, sir.
Yeah. You can take it from Rajesh, sir.
I will update on
Thank
our group. I will immediately update
Yes.
in the group.
Sir, I have
Thank
one
you, sir.
question.
Yes, ma'am.
Yes, please.
Sir, if we are instilling PRP in the endometrial cavity, in which phase of the cycle we'll instill that?
Yes, this is very important question. In fact, I showed it on the slide itself. It is to be done on 8th and 11th day of cycle, in which you are going to do a treatment.
Okay.
You have to do your standard treatment. Then you instill on 7th day and then 11th day, and you can continue your monitoring by ultrasound, and you should see the results.
Sir, if
So
it
the
is done in subendometrial installation, tissue activation is not required. Tissue itself will activate the platelets, no, sir?
Activation is actually already done by making it into a platelet concentrate lysate.
Yes, sir.
And my suggestion is to give 30x dose of PRP, so that you have very high concentration of platelet growth factors.
So is the
Generally,
mechanical
whatever
activation required if you are, is the mechanical activation required if we are doing it subendometrial installation?
freeze-thaw is the only best method available for activating.
Even
Yeah, but
for
you recommend
subendometrial
routinely. Do you recommend ready routinely?
Yes, for endometrium, yes. See, there are situations where we are injecting the PRP in tissues. Maybe
Yes.
it is an endometrium. When you are injecting inside the tissues, you don't need to activate, because the platelets are going to remain in the tissue for a long time, and they will release the platelet growth factors, and it will work. It is same way it is done in the skin, same way it is done in breast, same way it is done in joints, where they will not be going anywhere. But places where it is going to be removed, like in eye drops, like in the nose drops, like in the endometrial cavity, where it is going to be removed, in such cases, it is best to have a platelet concentrate lysate.
So that rapid action is initiated.
Rapid action and immediate action is available.
So this is very important take-home message for all of us, that when we are actually injecting in the endometrium, then it is not required. Activation is not required. But when we routinely use as an endometrial to inject in the endometrial cavity, like IUI with the help of IUI catheter, then it is better to activate PRP solution. Right,
Yes,
sir?
and activation is necessary because we are trying to simplify the procedure. The moment you say it is to be injected in the endometrium, it becomes a bigger issue. It's a bigger procedure. Naturally, it is going to cost more to the patient. It's going to be invasive procedure. Whereas instilling it directly in the endometrial cavity after the lysate formation is very, very simple.
So somebody asked that suppose they don't have liquid nitrogen, because in all IVF lab it is there, but somebody who is not having own lab and still they want to activate, what's the second best method?
The best method would be to do freeze thaw in the refrigerator in minus 20 degrees centigrade, like our standard refrigerator. Put it in refrigerator for half an hour, it will freeze, bring it out and thaw it, again do it. It will take time.
Okay.
Liquid nitrogen becomes very rapid.
So if that is not possible, sir, then?
Freezing is okay, no? In the refrigerator.
Okay. Deep freeze one can keep.
Yeah. Keep it in the deep refrigerator and bring it out.
Yes, sir. Any other questions?
Session. Dr. Vijaya.
Yes, please.
Time that can be taken between the PRP preparation and insemination.
Sorry?
Yes. What is the question?
Taken
Vijay.
between the PRP preparation.
Time duration.
Yes, time duration.
Time duration, like as I said, you can prepare from 30 ml blood, 1 ml PRP concentrate, instill 0.5 ml on 7th or 8th day, keep the remaining in refrigerator for about 3 days, and after 3 days, use the remaining one. So you can always store it frozen for at least a week's time. And we have seen in the eye, as an eye drop, it can be stored for more than a month.
Oh, that's very good.
Without losing
That's very
potency.
good. That's very good. Very good.
So my
So
question,
if we want, sorry, Dr. Boma, Dr. Sudekant, suppose we are planning to use PRP for thin endometrium successively 2 or 3 times in a cycle, then obviously we would to cut the cost or to cut the labor or for logistic purpose or whatever you say, we want to prepare PRP adequate at first go only. We inject some of them, and as you said, we can defreeze and it can reuse after 3 days. So in that case, the preparation method and quantity of collected blood and other things differ, or it is same?
See, basically, when we talk about the dose, we are talking about using 15 ml blood, preparing 0.5 ml and using it one time. Now, this proportion is to be kept everywhere. Now, you want sample to be made for 3 times use, then you have to collect 45 ml blood, make 1.5 ml, and keep whatever is remaining. Now, there is always a limitation in tapping the patient at one time. So my experience in doing this is we do it for P-shot. We collect 60 ml blood at a time and use it as a P-shot. So I think that would be the maximum which we can collect at one time. Beyond that, it will become like a blood transfusion activity.
Yes, sir. Yes, sir. Yes, Dr. Anupama Patil.
So can we combine PR with the bone marrow cell? Can we combine both?
Sorry, you mean the combination of PRP with bone marrow?
Yes, sir.
Yeah, my procedure of bone marrow, I'll share with you. It has a last step is you resuspend all the cells in PRP concentrate lysate and then use it as injection.
Okay.
My procedure has that step.
Okay, great. Oh. Sir, can you tell us what is the price of the kit?
Sorry?
Price of your PRP kit and BMD kit.
Ma'am, sir, telling price would be a commercial thing, but anyway, I'll share with you. The cost of PRP kit is about 600 rupees. Cost of bone marrow stem cell is just 6,000 rupees.
Okay. Just for the knowledge of everybody.
Yeah.
You're not audible. You're not
Cost
audible.
not-
You are not audible. You're not audible, please.
Sir, can you hear, sir?
Yeah.
Hello. Sir, we were
Yes.
buying a kit, PRP kit for 1,200 rupees, and they asked us to buy a separate centrifuge machine for that also. But the centrifuge machine did not last for long. It is requiring lot of repairs. So can you please demonstrate your centrifuge machine also if we buy the kit from you, sir?
The centrifuge machine which is required for my kit is very simple Remy centrifuge, which is very sturdy and goes for 25 years
Yes,
in
sir.
many of the
Yes,
labs.
sir. Vending is very sturdy, sir. The other one from where they were buying the kit, they asked us to purchase another centrifuge, which is not working well because these
Ma'am,
tubes are little wider.
commercially, what people will tell you, I will not be able to comment on.
Yes, sir. These tubes were wider, which did not fit into the Remy centrifuge.
I would suggest you to go for Remy centrifuge.
Yes, sir. That is available in all the labs. That will be much useful, sir.
But the
No,
tubing.
we have to use Remy R8C or R8C plus. That's the best
Okay.
centrifuge.
Okay, sir. So we'll wait for your workshop, sir.
Anytime,
Yeah.
ma'am. I'm always ready.
In this Remy centrifuge, probably the standard Falcon tube are the one which has to be used rather than the prepared ACD tubes. So that is the difference. Here you have to prepare.
My kit has an ampule of anticoagulant and Falcon tubes only.
And the Falcon
Okay.
tubes, what you give is bigger than the what we get in the market, sir.
Sorry, I couldn't get it properly.
Falcon tubes, what you give along with the kit are larger than that what we get in the market, what we use for the.
No, they are 15 ml tubes.
IUI. What we use for IUI are a bit smaller than what you.
For IUI,
Madam.
we use 10 ml tubes. For PRP, we use 15 ml tubes.
Madam, I tell you, if you aggregate everything separately, you might be saving 100, 200 rupees. But then it is better to buy a kit directly from him because straight away you are at least worry free and you are sure about what molecule and what concentration and what chemicals are using. Am I right, sir?
Sir,
Yes.
I'm using SARS only because I get them from him.
Yeah.
Yeah, we are using the same thing, the same technique what he taught us years back in Pune.
Yeah.
Yes, ma'am.
Sir, how can we get your tubes?
Well, just send me a message in WhatsApp.
Okay.
Sir, please check in chat box. You write your contact number.
Yes, sir.
Dr. Suryakant, please write down your contact number.
Where do I write? I don't know.
Chat, sir. In chat, sir. Chat.
Chat. Okay. I'll do that.
Next,
You click more and then you get a chat.
Otherwise, you speak, sir. You will write down.
We'll write down, sir.
so there's one more question. When we are
Yeah, I sent it.
Yes, sir. We got it.
So when we are injecting it in the ovary for ovarian rejuvenation, at what place in the ovary should we be injecting? It is in the cortex or it is in the medullary region?
Actually, it should be in the cortical region because that's where the activity happens.
But the blood supply is coming from the central area rather than the
Yes. It's not dependent on blood supply. Basically, what is important is we are providing them the stem cells, which will give you a paracrine effect. Paracrine effect basically is the effect given by the cells in the adjoining area, which are not in exact opposition.
And plus, these growth factors have got angiogenic activity also.
Yes, growth factors are also there.
Thank you, sir.
So, to all of you, those who are regularly using PRP, I'm sharing my experience. When you use PRP, may it be for thin endometrium, may it be for implantation failure, you cannot judge the efficacy of the treatment by increasing in the endometrial thickness or increasing the vascularity of the endometrium or changing the texture of the endometrium. Even if nothing is seen, if endometrium is looking as it was still it increases the implantation and pregnancy rate. It's my personal experience, and it is proven by literature also. So don't think and don't throw away these important modalities just by observing few cases where the thickness of the endometrium is not increased. Please remember, even if it does not increase the endometrial thickness, it improves your result. That's very important. And what do you expect? आपको कब खुश होना है? कब खुश होना है? When you use such a growth factor treatment, may it be a bone marrow, may it be a PRP, if there is an increment of 1.5 millimeter, you should be in heaven. Suppose initially you were 5 millimeter and then it has become 6.5 millimeter. Don't wait for 7 millimeter, 8 millimeter, and don't cancel the cycle. Be happy with the 1.5 millimeter increment and go ahead with your transfer.
Rajesh sir, one question to you.
Yes.
Sir, can we instill PRP after starting our LPS? If we have started luteal phase support, then can we use after that?
What is the idea?
So supposedly we have started luteal phase support and we are still
What's idea? What's idea? Luteal phase, please understand, all the receptor gene expression which are important for implantations are this only estrogen and progesterones are responsible for that. 70% the responsibility lies on progesterone, in 30% estrogen plus progesterone combined. So basically this growth factor, neovascular stem cells or factors which are responsible is just for the proliferation. We want to use this modality for the proliferation of the endometrium, not for increasing the functionality.
Okay.
Sir, how
So
many?
there is no point in using this in corpus luteal support.
Okay, sir. Okay. Thank you, sir.
Sir, how many cycles of PRP are needed for thin endometrium? And how long we should wait for the endometrium to become grow?
See, yeah, if there is an increment of 1.5 millimeter, you should be happy. Go ahead with the transfer. Even if there is no increment of more than increment of endometrium thickness, you may cancel once or twice, but still, suppose still there is no increment, you can combine GCSF with PRP. That is what we do. We give GCSF injection in the morning, and for the best efficacy to mobilize all the growth factors from the bone marrow, we do PRP in the afternoon. So try this, and even after doing this, if even still endometrium is not increased, we have gone ahead with the transfer and we got a result, and I updated this result in our group many times. So don't have any inhibition or any limit on your mind that okay, before this much thickness, until the endometrium has reached to this thickness, I will not transfer the embryo. No, please remove that inhibition from your mind.
Sir, good morning. Intrauterine or subcutaneous?
Routinely, we are using GCSF subcutaneous. We see GCSF when I'm combining with the PRP, I use GCSF subcutaneous. If GCSF I have to use only for implantation failure, but to increase the implantation, then also subcutaneous. But if there is a associated thin endometrium, then I use, if I do not have to use PRP and I've decided to use GCSF only, then I will use intrauterine. That's my way of doing.
Thank you, sir.
Sir, good morning. You are using instillation or injection?
No, injection with the, you're talking about intrauterine?
Intrauterine.
Yeah, with IUI canal, obviously.
Installation. Okay.
Good morning, sir. I have one doubt for the hello.
Yes, yes. I
So,
would request you, listen. I would request you any technical
hello.
difficulty. Sorry, because Dr. Hayat is already tired. So I would request you any technical thing or anything related to PRP or bone marrow. If you want to ask, first ask him and let him free, and then we are open for rest of the discussion.
Sir, I just want to ask, good morning, sir. The dose of PRP for ovarian cortex said just now. So how much dose and how much ml we should inject in each ovary? If the patient has like AMH is, less than 1.
Dr. Suryakant?
Yeah. See, basically, when we are talking about ovary and the dose of PRP to be injected, again, it has not been determined or discussed in any of the literature. But my suggestion would be to use all the platelets derived from 15 ml blood into one ovary. Now, how many ml to be injected is again a theoretical question, because what is important here is not the ml quantity, but the quantity of platelets which are going in that.
Okay.
Now, what you do is you concentrate all the platelets into 0.25 ml from 15 ml blood and inject in one ovary, and ensure that all the prepared PRP has gone into the ovary. This is very, very important. Nothing should remain in the needle and syringe. That's the technical aspect.
Yes.
Sir,
From the
after
menstruation.
how long after this ovarian PRP or stem cell we have to wait for the stimulation, sir?
Next month.
Generally, any of these stimulations have to be repeated after 1.5 months, that is 6 weeks period, and 2 to 3 cycles to be done to say that it is not working. But you may get result even after 1.
Okay, sir.
And sir, and one question is, sir, one question I have, suppose liquid nitrogen sometimes we not get. If you keep in the fridge, so for how many time, for how many minutes, half an hour?
See, basically, when we are freezing in the refrigerator, it will take little more time to freeze, because it will take about half an hour to freeze.
Yes.
And then you thaw it in about 1 or 2 minutes. Again, you freeze. Again, you thaw. So it may take about 1.5 to 2 hours to complete that whole thing. And when we are using liquid nitrogen, the whole thing will be done in 5 minutes.
5 minutes.
And now newer refrigerator, they have got that function of rapid, freezing, rapid freezing.
Okay. Thank you, sir.
So that can.
Sir, any ICM or regulations for this, sir, for treatment purpose only, not for culture?
Are we talking about the treatment for the patient, or are we talking about only the regulation part? If we talk about the regulation and if we go to ICMR to do that, even they will allow you, they will ask you to take permission for collecting blood sample for testing.
Yes.
So we need not go to them. See, basically, these are minimum invasive techniques. The techniques have been classified all over the world into one is minimum invasive technique or minimum manipulation techniques. Like we collect blood, we centrifuge, separate something, and then go take it back. We collect bone marrow, separate and put it in the patient. We collect adipose tissue, we find out the stromal vascular cells, separate them and inject. Now these are minimum invasive techniques. Platelets also same in the minimum invasive techniques. Now when we talk about the maximum manipulation is like you separate the bone marrow cells, you put them into culture conditions, you try to increase the number, you try to change the character. In that case, it is maximum manipulation, for which, yes, you require a license.
Sir, for how long we can store PRP in liquid nitrogen?
But why do you need to store?
No, sir, you said that we prepare 1.5 ml. Suppose
only for the cycle we have to use.
So how many GCSF before you do the bone marrow stem cells, sir?
GCSF?
How many GCSF? Yes, sir.
I have no idea about GCSF.
No, to
Dr.
stimulate
Rajesh
the bone marrow
talking.
cells, sir. To stimulate the bone marrow cells, are you giving before doing the stem cell collection, sir?
It's not required.
Okay.
See, when we give GCSF systemically for the stem cells, generally that is used for collecting the peripheral blood stem cells, not for bone marrow.
Okay, sir.
True.
Sir, good morning. Which phase
Does
of the
PRP
cycle we have to inject PRP in ovary? Which phase of menstruation? Luteal phase or follicular phase?
Basically, when we are talking about the ovarian stimulation or ovarian
Yes.
thing, generally these patients are amenorrheic.
Right, sir.
That's the reason why we are taking them up for ovarian stimulation. So in that
Okay.
case, you can do it anytime, and every
Right.
1.5 months, that is 6 weeks, you can repeat.
Okay.
Logically, it should not make any difference because there is always a because the purpose of doing ovarian rejuvenation is to activate the certain dormant follicles which are not recruitable, and still they are not going into apoptosis, still remaining dormant. That's the whole idea of doing ovarian rejuvenation. So it can be done
Thank
at
you, sir.
any phase of time.
Thank you, sir.
Sir, what is the anticoagulant you are using and what is the buffer?
It's a very, very important question.
Yes.
If we talk about anticoagulant, there is a complete spectrum of anticoagulants available. The blood banking uses ACD, that is acid citrate dextrose, or CPD, or CPDA is used for blood collection. Then we have heparin, then we have EDTA, then we have citrate, and many other anticoagulants. But what has been found for platelets, which can support the platelets, is sodium citrate only. Plain sodium citrate is required. Plain sodium citrate in the concentration of 3.8% will give you 1 ml to 9 ml blood proportion, and that is ideal.
Any other question related to technicality of the PRP and bone marrow?
Injection help in age-related poor ovarian reserve?
Yes,
For ovarian,
you can
yes.
try. You can try. You can try. Even the pregnancy has been noticed in postmenopausal women also.
So ovarian PRP injected transvaginally as well as laparoscopy, so we are doing only, but we can inject this transvaginally. This
Why not? Why not? It can be done, but technically to stabilize the ovary is a challenge. If you do any manipulation on unstimulated ovary,
and on which day of the cycle, proliferative phase or secret?
doesn't make any difference.
Okay.
Sir, do you use anything for activation of these platelets?
As of no. As of now, but I will start doing this thing, freezing and thawing.
We have to stimulate the ovary prior to PRP in ovary
No, not true.
with letrose or cycling. Is there any benefit?
No idea, and nowhere mentions the thing.
Okay. Thank you.
Okay, I believe there is no more question
Sir?
regarding PRP and the bone marrow. Yes, please.
Sir, I have some few talks I heard about this ovarian PRP is not useful for this activation of even dormant follicles. What about your thoughts about that, sir?
I have not done enough cases to comment on that, but yes, you are right, absolutely. The Dr. Sankalp Singh has done more than 500 cases, and he condemned this technique of ovarian rejuvenation, and so he, as per him, adequate what you call results are not there to suggest it routinely, but nothing else is in our hand. So whatever is in our hand, we must try. We must try. And see.
Okay.
Can I add one more thing, sir, in this? The reason why these procedures fail, or they are bound to fail, is because of the technical problems in doing the PRP, which nobody even bothers about or nobody even is aware about. Many a times I have seen people are using 5 or 6 ml blood sample and using it for doing PRP. That too after very high centrifugation, where they take out the plasma from top, and that plasma is absolutely devoid of platelets. Now, if you use that and start saying that it doesn't give any result, has no meaning. Unless you are very sure what platelets you have injected, whether the concentration was proper or not, whether the yield which you received was proper or not, it is very difficult to say about that. And many of the kits, I am very sorry to say, many kits which are available in the market do not work at all. That's the reason why, which prompted me to develop my own kit. I had seen this whole kit almost 7 to 10 years ago, when some American company was selling 3 tubes of gel for 14,000 rupees. And that's where I really gave me a shock. I said, even collecting the whole blood and preparing platelets from that cost less than 1,000 rupees. Why should it cost 14,000 rupees for doing 3 processings? This is how I started working, and I started developing my kit based on standard blood banking principles, which give me a very good result.
Yes,
Thank
sir.
you, sir. Sir, I have one doubt. Once you do this by your method, the PRP, this platelet, can we see in microscope under the cover?
You
Put
can
the slide and put
see them under in the microscope. You can do a Coulter count of those platelets. Again, there will be a rider on that. Rider is the moment you do all this processing, the platelets start getting agglutinated, which will lead to a spuriously low count. But what you should look into is platelet crit. Platelet crit should go 10 times.
how that will, how can we
You have to
find
do
out?
with the five-part differential machines which are available in the market. You can send it to a lab and they can do it.
Okay, sir.
That's the process which I commonly use. Whenever I have to check my platelet counts, I always send a drop to the lab and ask them do the platelet count for us, normal labs.
How much concentration is desirable for 15 ml
7
of
to
blood?
10 times.
Okay.
And for endometrium, 30 times.
Okay, thank you, sir.
So any question? If there is no question, we can request Dr. Hayat Nagarkar. If he wish, he can leave. Otherwise, he can be.
Sure,
He
sir.
can
Thank you
remain.
very much.
Yeah. Thank you,
Thank you
sir.
very
Thank
much,
you
sir.
for. Yes, sir. Yes, sir.
Thank you
And
all for patient listening. And whenever you have any doubt, you can always send me a message by WhatsApp. I will always respond. Thank you.
thank you, sir. Thank you. So now the discussion is open for any other doubt pertaining to any particular practical questions or any difficulties which you have come across. I will be happy to answer for next 30 minutes.
Sir, do we have to take any permission for the stem cell injection?
I don't think. Nobody's taking. That's what I have seen. Really, I do not know whether
Can I
it is
answer this?
required. Dr. Anupama is there.
Can I answer this? I'm just saying that when we were doing IVFs earlier in this pre-ART law era also, we were doing ART. There were no specifications as to what to do, what not to do. Similarly, I mean, there is no rule that you are not to do it. So then do it. I mean, whenever regulations will come, only then be scared. Till then, you are doing autologous thing, taking things
Because
from.
these are not gametes. No? These are not gametes. So Dr. Anupama will not mind it.
No, sir, it's not gametes. It's an autologous thing. It is not dangerous to the patient. So
Yeah.
where are the rules and regulations? I mean, if we are doing it from one person to another, from chuha to a billy, then it is a problem. What is the problem here?
Yes. Any other question?
Sir, one question I had to ask, what is the name of that fridge company which give you rapid freezing? Because I had to buy on Amazon.
Not any this good company. The one freeze which I use in my consulting room, because I need a lot of this thing, the ice
Yes,
packs,
yes,
because we have to give parcel
yes,
of
yes,
injection to the
yes.
donor.
You don't
So I need many time I
store
need
this in
rapid freezing.
Yes.
So that is good freeze. That's a model from Samsung.
Okay.
So you can verify. I that at least in that freeze it is possible to do rapid freezing.
Dr.
Okay.
Supriya, you don't use the semen freezing sample or something. No containers are there. It's very simple. In dip in that only. In the fume,
Okay.
that is enough.
No, sometimes it is difficult to get liquid nitrogen, so that's why I ask sir okay, for rapid freezing for the fridge, if
Those
it
who
is
are
available.
having those who are having IVF lab, they are bound to have liquid nitrogen.
No,
But
most
so
people who are doing
no problem.
IUIs, even though people who are doing IUIs are usually having the semen containers, they freeze
Yes,
this.
yes.
So that is good enough. You can do with that.
Okay, okay. Sir, one thing I am using for my patient a hysteroscopic guided PRP. So doing the laparohysteroscopy for the patient for thin endometrium or any first time for the any primary infertility or secondary infertility patient. So I inject hysteroscopy guided with the ovum pickup needle sub endometrially, and it giving the good result. But I'm taking from the blood bank, and they cost me 1,400 for that PRP 20 ml. Hello.
20 ml PRP.
Yes, in that bag.
How it is
PRP.
possible? How it is possible? 30x platelets, uh, autologous platelets, 30x autologous platelets, and 30 ml is not possible. How it is possible? I don't know.
I tell you, sir, what happens. People are giving the platelet poor plasma as well, rather than platelet rich plasma. We have to take the coat just above the platelets. That is along with the platelets. That is the platelet rich plasma. This is a very common problem. And when we are using this, then we are actually not getting good results. So that platelet poor plasma is something which we have to understand.
Sir, they are taking the blood one day before prior in their blood bank, 100 ml blood, and out of that they're giving after 24 hours by agitation method, they said. I don't know.
I do not know. I'm not aware.
But the results are there, so I'm using that. Urban Blood Bank from Nasik.
No, I'm telling you for sure. I had read this for this verdict conference only, and this is not the way to prepare it. Whatever they are doing, as sir also just now said, Dr. Surikant, that these are all gimmicks that they are doing for marketing. Actually, that is not the adequate way. This is the only way.
Yes, we'll try this only now.
Yeah. Any other question?
So can we take some other questions apart from this?
For sure, for sure.
Sir, can you just tell the benefit for the benefit of all of us, say during pickup, if we come across a dermoid cyst or we come across endometrioma, what all precautions should we take?
So, do you think, is it possible it comes unknowingly? No, never possible. So, when you're doing your scan while you're stimulating the patient, you always come to know that there is some cyst, maybe unknown nature, which is there in the ovary. So, you always try to map the cyst and try hard not to puncture it. May it be dermoid cyst, may it be endometriotic cyst. Now, suppose the patient is of diminished ovarian reserve, and there are very bright chances that you may puncture, even if you try to avoid, or by mistake, suppose it has been punctured. you should not be, hyper by any means, because it has happened many times, sometime deliberately, sometime accidentally with me also. And in none of the case, the ovarian abscess or something like that has occurred. So only precaution which is required to be taken, because you come to know some another kind of sticky fluid or maybe brown color fluid, chocolate color fluid has started coming in the tube. So the tube where always some eggs were there, follicles were there. So immediately send that tube and tell the embryologist to wash on priority base. So immediately they will separate the OCC complex and wash with the media immediately on priority base, and then we can go ahead in a routine fashion. That is one thing which can be done. Second thing, good antibiotic is needed. That second thing. And third thing, if priority, by priority, if we are knowing that we are dealing a case of endometriosis, we can uh, do asepsis of vagina by using mild betadine solution, maybe 1% betadine solution, and then after using betadine solution, we can wash we can wash again with the we can wash again with the normal soap. So that is what precaution. Regarding the dermoid cyst, I never come across the dermoid cyst, but then I know a couple of days back you were discussing with me some different viscid liquid has started coming, and then the oocyte yield was suffered, and you doubted that some of the oocytes, OCCs, were entangled in the viscous fluid, and
Velvet.
maybe lying in the tubing, or maybe lying in the stick to the wall of the needle or something. This type of problems can happen.
Thank you. And in this situation, if it's an endometriotic cyst, should we attempt the sclerotherapy in such a situation?
Yes, sclerotherapy at the same time, you mean to say?
Yes, yes. After doing our pickups,
Yeah,
can we inject the alcohol in them?
that's a good idea. That's a good idea.
Mhm.
That's a good idea.
But usually when we are finished with it and our needle has, by chance, we have withdrawn and we have completed our pickup. And after that, if we are wanting to do the sclerotherapy, then the problem is that we are not sure that we are reaching at the precisely same site or not. So in that situation, should we be attempting, or it should be done only when we are into the cyst, then only we should be attempting?
Absolutely. Because unless the sclerotherapy is beneficial in case of endometriosis, it is damaging in case of simple cyst. So you have to be very sure that it is endometriotic cyst.
Hmm. Thank you so much, sir.
Yeah.
Sir, they are in the lab, they're giving 95% alcohol. So how to prepare that 70% alcohol?
By diluting water, distilled water.
How much water and how much alcohol, sir, for
It's a
sclerotherapy?
mathematic calculation that embryologist does. So it is a
Okay.
mathematic simple calculation.
Okay.
See, see, simple. Put a equation. If it is a 70% alcohol, 30 ml is a distilled water required.
Yes. Yes.
If it is a 95% alcohol, how much is required?
5
Something
ml
like
water. Okay.
Something like that.
Check. And you inject it and keep it for 10 minutes during procedure?
Yeah, at least 10 minutes.
Okay.
And then I re-aspirate, and some of the alcohol I keep inside.
Yes. Okay. Thank you, sir.
Yeah.
Sir, how much ml we have to use for the sclerotherapy, sir? 70%? How
That
much
depends
ml
on
we need
that
to measure?
depends on how much endometriotic
Size.
fluid you removed.
Okay.
So roughly it should be uh, one third, one third of that, one third or one half of the liquid which you have removed.
Okay, sir.
So have you ever
Thank you, sir.
attempted this stem cell therapy and bone marrow aspiration?
No, never.
I was just wondering which needle would we be using for bone marrow aspiration. So must be some different needle.
No, there's some Indian name is there. I forgot the name for bone marrow.
We had
That we
mentioned
have.
it, yeah, in the
Yeah, it is
presentation
mentioned.
it was mentioned.
Yes, yes, some Indian name only. So that needle has to be used, but we cannot. We have to call orthopedic surgeon. We can't do.
Oh, I have an in-house surgeon.
Yes, your husband is orthopedic, no? Am I right?
Yeah.
Madam, the picture I have put up in the group, madam, needle picture, and we can use that needle 5 to 6 times, they told.
Oh, yes.
Okay.
Something from
Cost,
J.
how
The
much?
name starts from J something.
Cost. How much it
Jamshedji,
cost?
if I'm not mistaken.
It's very cheap, madam, not costly.
Okay.
Jamshedji or something.
I think somebody had showed in our Vadi group picture of needle.
Anupama has
Yesterday, I think. Acha, acha, okay.
Anupama Patil had put that picture.
Acha, fine.
So, wind up kare abhi?
Good morning, sir. Can I ask something?
Yes, yes.
Good morning, sir.
Good morning.
Sir, in the positive group 3 type patient, I gave her OCP for 15 days, then followed by estrogen in the luteal phase. And after on the 6th day of OCP, when finished, I started gonadotropin. So she had the message on the 2nd day after the starting the gonadotropin.
No
So
problem.
she can be done for fresh embryo transfer.
Why not? Why not? For sure.
Because the message started after the injections.
That's fine. That's fine. There is no problem.
Thank you, sir.
Yeah. All right.
Okay, thank
Okay,
you.
We
sir.
end the
Thank you so
discussion.
much, sir.
Thank you very much. Thank you.
Sir, I have one doubt, sir. Antac protocol, how long the stimulation can be continued, sir?
Sorry. Can you repeat?
Antagonist protocol for the IVF stimulation, how long?
Antagonist protocol. Antagonist
Yes,
protocol.
sir. Yes, sir. The maximum
So,
stimulation.
So, unless it is PCOS, it has been found that if the stimulation lasts more than 13 days,
Okay.
then your outcome is not good.
Okay, sir. More than 13 days.
Yeah, unless it is a PCOS.
Okay, sir.
So that is one aspect. Second aspect, after acquiring a trigger criteria, how many days more can you pull? That's another question. Suppose you have acquired a trigger criteria on stimulation day 11, for example.
Okay.
So can you go up to day 13? Yes, you can.
Okay.
There is no disadvantage, but there is no advantage also. There is no advantage also.
How many days can we pull?
Two days, up to 2 days, there is no problem.
Okay.
If more than 3 days, more than 2 days, then in antagonist protocol, there are chances of altered receptivity window. Implantation may be disturbed. So better to avoid a flash transfer.
Okay, sir.
Yeah.
Thank you, sir.
All right.
Good morning,
Yeah.
sir. Sir,
Good
in
morning,
the
Dr.
long
Hital.
letrozole protocol in case of PCOS, so for how long can you give letrozole in the long letrozole protocol for PCOS?
Long letrozole, you mean to say extended letrozole protocol?
Yes, extended letrozole. Yes, sir.
Up to 7.5 milligram. You are talking about step up or continuously same dose?
No, continuous same dose. For how long can you give? So like I have stimulated one
28
patient
days.
on that.
28 days
20
also
days.
it can be.
Okay,
20
okay, okay.
28 days also it can be there.
Okay. And on day, I started extended letrozole, and on day 13, there were some activity like the follicles grew around 12 to 13 mm. Then can I add HMG to it, or I shouldn't do that?
See, if the follicle is recruited and reached up to 12 to 13 millimeter,
Hmm.
it will reach to 16 millimeter also. It will reach to 17 millimeter also. Why you want to add HMG?
Okay,
HMG,
okay.
if at all, if you want to add, and that is what I practice, I never
Hmm.
give letrozole more than 7 days. So if the follicles are most of the time when a letrozole has to act, most of the time some follicles are recruited by 8th day of stimulation, after 7 days of
Okay.
letrozole stimulation. If that does
Okay.
not happen, then I do not want to waste time. I give only 3 doses of HMG, and for sure the recruitment is there.
Okay. Okay. Thank you, sir.
Thank you. Okay, goodbye. We end the meeting.
Thank you, sir.
Thank you.
Thank you,